Good evening, all. Um, I'm John Allen, taking the healthcare reform course with y'all. This is my presentation about issue facing healthcare today. So the issue that I wanted to talk about is the closure of safety net hospitals. What I realized as I began to read up more on this issue is that it was probably a broader topic than I wanted to do in a short presentation or a three-page paper. However, it's something that kind of comes near and dear to my heart, so let's get rolling with it. To start with, this is University Hospitals Bedford Medical Center, which was closed last year, cited due to staffing issues. So, first question, we need to have a common framework as we're discussing this. We need to know, what is a safety net hospital? And the truth is, this is kind of poorly defined. Did a little bit of background reading. There have actually been a number of academic journal articles discussing what the definition should be and concluding that there wasn't a clear definition and needed to be. But everyone seems to agree that these hospitals have a large percentage of their patients being either Medicaid or charity care. Now, when safety net hospital funding was distributed in the pandemic and COVID-19, this was around 20.2% or more was the number they used. New York State's general definition for a safety net hospital is a little more stringent. It's closer to 30% Medicaid. But regardless, everyone agrees it needs to be a high percent of Medicaid. The other thing that everyone seems to agree on is that these hospitals tend to have narrow operating margins. Oftentimes this is cited as being around a 3% profit margin or less. And then a lack of other accessible care for patients. Now, what this means can vary depending on the location. If it's a very remote rural location, it may mean that there's no other hospital for miles and miles around. If it's a more urban area, it may mean that there aren't good transit options for patients to get to the next nearest hospital. So, as I mentioned in the next bullet point, these can be urban, suburban, or rural. The interesting thing I found in the literature is that the urban population, they tend to be more Medicaid. Rural tends to be more charity care that they end up giving away for free. Regardless, these kind of hospitals tend to exist just about anywhere. It's just a matter of there being larger, lower income communities. So why are they closing? Two broad reasons. One is finances, which, like I said, lots of Medicaid, narrow margins, and every hospital lost money during COVID, pretty much. Care for COVID initially was very expensive. We didn't know what we were doing with it, and we were losing money because everything that is normally done electively, where the hospitals make all their money, had to be canceled to make room for more COVID care. Facilities that operate at a very narrow margin to begin with don't really have the income stream to make up for it when they are put under a lot of stress, like they were in that situation. So a lot of them just never caught back up and eventually end up closing down. The second reason, and the one that gets cited a lot with some of these closings, is staffing. Now, staffing, it's an issue everywhere. Depending on if it's a poorly run organization, it can become a self-fulfilling prophecy where you don't have enough staff to begin with. You're not making the effort to bring in new staff, so you have poor working conditions, so more staff leave, higher, this is backwards on the slide, I apologize, higher patient to staff ratios, which leads to worse patient care. Then you have fewer patients. Now you have less money to recruit and retain quality people. The other thing also with staffing is that COVID brought the issue to the forefront because a lot of nurses who were working at places where they weren't paid very well, where they weren't really being treated very well, left and took lucrative travel jobs. So now many of these same facilities are now paying more money to bring in travel nurses to replace staff nurses as a result. So here's as we shift gears, here's Good Sam Hospital in Dayton. This is actually where I was born. So what can we do about all these things closing? We could do nothing. Eventually, all the safety net hospitals will close. There'll be none left, and people can either figure out a way to travel despite lacking resources or just not get care. Personally, I think there's kind of a moral imperative to provide care, especially to people who are, let's say, struggling a little bit more. So I don't think that's a great solution. Next option would be money, which money has to come from somewhere. I know at least in Ohio, our political climate is probably not going to be one that favors increasing taxes to give more money to low-income healthcare. So is that likely to happen without some sort of payback mechanism in place? No. So my third thought was to rethink how we approach staffing and retention for these facilities. And that's what I want to focus on in the remainder of my talk here. So there's Hahnemann University Hospital in Philadelphia. It was a huge, huge medical center that closed down. They were very big in medical education as well, so it led to a lot of trainees who were effectively orphaned partway through a contract without a license to practice independently. So that's another thing that comes up when these places close, is that they tend to be involved in medical education, which tends to cause problem. Well, realistically, I think it'll probably be a generation before we see all the impacts from Hahnemann's closing, because it was such a huge institution. So, rethinking staffing and retention. What I would like to do is to consider the U.S. military medicine as our model case for this. So what you need to know is that the military pays significantly less for typical physician, around half to two-thirds as much. For people in more lucrative fields, it's more like a third as much money as they would make in an equivalent civilian role. But it's able to maintain staffing, and it offsets this by providing large scholarships as well as stipends during education for trainees. The exchange of this being that they are locked into a contract upon graduation. Typically for the armed services for physicians, it tends to be 1 year plus 1 year per year of scholarship support. So minimum 5 years for medical school. So what I would suggest we do to provide staffing for these places is to provide a scholarship with a work-off obligation. So this does require a significant initial investment, but it will pay off in the long term. So like I said, military physicians, they make about half what their civilian counterparts do, but cost of medical school for the entire 4 years of medical school tends to be around the same amount of money as a year of physician salary. As a result, the break even on providing a scholarship to someone to get through school is about 2 years out, right? If you're paying them somewhere around half to two-thirds of what they would make otherwise, then we're looking at 2 years and then you break even. We can be more generous with the finances, and then the break even would push out somewhere further along, like 3-4 years. Now, if the initial contract is 5 years, clearly you don't want your break even timeline to be longer than that. So a big concern with this would be, people can leave and look for market rate contracts once this initial time period is up. So 2 things we could do to address this. Either one, we accept attrition knowing that essentially by the end of that contract we're already out ahead financially versus what we would be to hire someone, or you pay these people. You know that they've already spent 5 years working in your community. If they want to stay, they're likely committed to serving that community. So the people who want to stay would become your sort of reliable, more bedrock type employees. In any case, our goal twofold here is to work out financially an effective solution and to work out in terms of just having staff on the floor to keep the building open. In either case, I think we've met this goal. Here's St. Vincent Charity Hospital in downtown Cleveland. It recently closed with very little warning. I have had patients who have come to me who said they showed up for an appointment one day and the door was just locked. So, yeah, these things often happen without an appropriate wind down period as well. So, who are the stakeholders for this plan? In a broad sense, I could say everyone. That's a little facetious, though. in a more realistic term, our local governments are going to be major stakeholders. They're going to have to work with these hospitals to figure out how we can get the initial investment to get the ball rolling for such a program. Additionally, to the local governments, the state government, just because a lot of these hospitals by nature are in municipalities where there's not a lot of money to go around to begin with. So probably the state government would have to kick in something as well. A little more creatively, we could talk about medical centers in neighboring communities. For example, here in Cleveland, when Bedford Medical Center closed, since then, Ahuja Medical Center in Beechwood has been sort of a little bit overrun with the folks from Bedford, who now Ahuja becomes the nearest ER. So I think you could make an argument that it is to the advantage of the folks at the neighboring medical centers to avoid having more patients than they're capable of caring for to help support their neighbors. The other thought would be universities. Like I said, this plan is predicated on offering scholarships. And if we offer those things locally, then ideally you would be bringing in local talent, keeping them local and engaged with the community. The other thing to keep in mind is that the safety net hospitals, one of the ways in which they've historically been funded is by providing education. They get money from the schools, they get money from Center for Medicare Services to train residents. So again, really leaning into that existing education background to help with the funding and the logistics for this plan. Here's a former Mount Carmel West in Columbus. This was closed and then moved out to a more, shall we say, suburban community. It was previously in the inner city. So my conclusions, safety net hospitals are necessary to provide care to a wide variety of people and often have to do so at a loss. All hospitals face some financial challenges during the COVID-19 pandemic, but many of these safety net institutions were never able to recover. Again, their margins are narrow to begin with, and when they face major setbacks like that, they don't really have a good revenue stream to make it back up. And something I did not perhaps touch on as well as I should have, but the nature of the patients that are seen at these hospitals, many don't have a good way to travel to the next hospital. If the next one is accessible by bus or train, sure, maybe. But if you need to get in the car and get on the highway, that may not be feasible for a lot of folks. So keeping care local, it's not only a question of making it easier, it's a question of making it accessible at all. And then, as I mentioned, developing training pathways similar to what's used by the United States Armed Forces can help us provide high-quality, cost-effective care, which can help address our staffing shortfalls. In the long term, it could save and potentially even make money, but it needs a short-term cash influx, which would likely require outside funding, hence the broader community stakeholders. So, will this fix everything that's going on with American healthcare? I really doubt it, but I think we could potentially solve a very small piece of the puzzle and help keep care in these communities that really need it and oftentimes get overlooked. Thank you. Oh yes, I'll close with University Hospitals Richmond Heights. That also is no longer around.